We introduce the new panelist, Professor Alina Gerrie from Canada, hematologist and associate professor at the University of British Columbia, member of lymphoma tumor group at BC Cancer. She is an active clinical research in CLL and will share the clinical perspective on how to make complex medical information accessible. The other discussant is, please come. Okay, no problem. No, okay. Please. Okay, we start with the slide. After we join the other people. Okay.
Have this here just for time. Okay. Can you hear me okay? Oh, I can stand. Okay, yeah. I don't mind. Okay, I can stand, sure. That's probably easier. Thank you. Oh, and there's a timer. Perfect. All right. Hi there. Thank you so much to the organizing committee for inviting me to speak. And I was tasked with speaking about health literacy. This session is bridging the gap between care and comprehension, and we're going to have myself give some perspective and then hear from advocates from both high-income and lower-middle-income countries for the panel discussion. So I just have about 15 minutes, and the slides are really just meant more to guide discussion, but I'll start here. So here is a typical day for me in a hematology clinic. So I saw, and this is a patient that I saw, a 55-year-old gentleman who had newly diagnosed CLL. He was early stage, RISE stage 0, and he was feeling well, asymptomatic, what we call it. So I explained with my team, I have a nurse in clinic as well, and usually a resident or trainee with me, and so we explained what CLL is, that it's a blood cancer, a type of leukemia. We explained that there's many excellent treatments, but it is an incurable cancer. And we explained how there are certain reasons why we treat patients, what we call indications to treat. And at this time, he didn't have any indications, and we planned for what, as I think many of you know, we call watch and wait, or another term is active surveillance. So he was understandably upset at this new diagnosis. He was aware of it before coming to clinic, but of course, hearing more about it, he was emotional. He was very anxious. We gave our patient handouts. We give support group information, including for CLL Canada, as you heard Raymond discuss. And we made a plan together to check in again in 3 months and see him at that time. And for me, this is a typical day in my clinic, but I can very much appreciate this is not a typical day in someone's life for the patient. 3 months later, he came back to clinic. This time he was alone. I was very surprised to learn at this point that he had actually quit his job. He was 55, so not really near retirement at that point. He's now on long-term disability. He'd had so much stress over the last 3 months related to his diagnosis and then the issues around quitting work. He'd actually broken up from the long-term relationship. The partner was not there with him anymore in clinic. He was really overwhelmed. He was finding it hard to cope with day-to-day life. He was considering selling his home and was talking about wanting to travel for the time he had left. And I realized that, or I had to ask myself, what went wrong in that first conversation? Because that is not when I was explaining to him about CLL, that is not the picture that I have at all in my mind. And I realized that we clearly had not communicated this effectively to the patient. And I share this story not to say that there was any deficit or it's not a misunderstanding on the patient's point of view. I really think it's something that as clinicians and as an organization and a system that we have to do better at explaining. We didn't convey that early stage CLL has an excellent prognosis, that even if he needs treatment, most of the treatments nowadays are very tolerable and manageable, and side effects we can adjust, or we have other treatment options we could change to. And so a lot of these things weren't conveyed in that meeting. And I think this is where we need to think about how we can do better as an example in terms of our communication. So what is health literacy? So there's actually definitions from the World Health Organization and the Center for Disease Control, and they all center around the same concept, which is being able to find, understand, and use health information and services to inform health-related decisions and actions. And interestingly, they've also defined organizational health literacy, sort of speaking to what our previous speaker talked about, that there's also a component of organizations that need to be aware. And this is the degree in which organizations can equitably enable individuals to find, understand, and use that health information and services. And again, really to point out that this is not a patient problem. This is a system issue and a clinician and organization issue. And as sort of highlighted before, health literacy affects everyone. So even highly educated patients, like many of you in the room, you know, there's still components that can be misunderstood and you know, where we really need to improve upon. So I think you guys are probably all aware of many of the common barriers patients face, certainly medical jargon, and we're horrible for using this in clinics with patients. Even words that to us seem very straightforward: oncology, progression, palliative. These are terms that you know, we really need to ensure that our patients understand if we're using these kinds of terms. Information overload, and we're all, again, systems issues, we're all confined by time constraints. You know, a 15-minute visit, you might hear 10 new terms, 3 new medications thrown at you. It's a huge amount of information to process in a short period of time. System complexity. The medical system, it's extremely complex. Referrals, tests, wait lists, now patients have portals, you need logins, there's all sorts of things, all very hard to navigate. And then, of course, there's equity challenges, language, cultural, financial, of course, and then patients in more rural or low middle income settings, of course, have additional challenges. So what can clinicians do differently? These are things that we try to think about in our clinics. We want to try to simplify information, not patronize, but simplify what we're explaining to patients, trying to use everyday words instead of medical jargon and shorthand. There's a concept called teach back or share back, where you sort of ask the patient to explain what they heard. I often when I see a patient, already a trainee or someone else has been in and had an initial discussion. So when I come in, I'll often start with, what's your understanding of why you're here today, or of what we've discussed today? And I'm actually very surprised. Often people, they're nervous, I understand that as well, but often they really can't say back what I think was discussed earlier with the resident, for example, even the diagnosis or why they were here. Written and visual aids, that was already discussed quite a bit in the previous session, so summaries, infographics, diagrams, but it has to be targeted to your patient and culturally appropriate. In Vancouver, we have a large multicultural population, many different languages. Some of our material is translated into the more common languages, so we have a lot of Chinese or Mandarin and Cantonese speaking patients. A lot of our information is translated into specific languages, but of course not all. That's where something like the CLL Advocates Network, there's the resource hub that has links to different patient organizations from different countries, and I will use that in my clinic if someone's from a place where I might not have our own translated information. And then we really need to normalize questions. Instead of saying, do you have any questions? You know, what questions do you have? I try to say things like, often if people are, I understand, they're nervous in a clinic, they're overwhelmed. So I might say something like, often I see patients in your situation or people in your situation might be wondering, what does it look like when I do need treatment? Or how is this going to impact my work, my financial situation, and try to open those conversations that way. And so again, to emphasize that I really do feel these are clinician and team and organization responsibilities. These are not patient deficits. And in CLL in particular, kind of alluded to in the last session, we actually are fortunate because we often have a really long kind of preparation time. So during that active surveillance period, this is a really fantastic time to introduce concepts. We have a bit more time. We can introduce them slowly. You can bring them back to reiterate things. And then, as Dr. Kennedy said in the last session, if you can kind of predict when someone might need treatment, and it's often 3 to 6 months down the road, so you can start to talk about treatment. One of the hardest clinic conversations to have is to explain to somebody about indefinite treatment with a BTK inhibitor and all the side effects and consequences and the names of all the different drugs that go with that, versus fixed duration treatment, and try to explain venetoclax and the ramp up and the obinutuzumab, and that is, more than an hour right there. So to start those discussions slowly as you're approaching treatment, and then to provide resources like advocacy groups where patients can reach out to, I think is really crucial. So I think we all have a shared goal. We know that clear communication is good care. Trust grows when information is understandable. I think patients, clinicians, and advocates all have a role. We know that improving health literacy can provide a foundation in which patients can play an active role in their own health. And also it can hold organization and government accountable for addressing health and health equity. So advocates are essential partners. You can really help us reinforce, explain, and empower beyond the clinic room. Help translate our doctor language into human language, because we won't get it right, even when we're really trying. I think about a time, it stands out in my mind, I was the family member of a patient. It was my mother going through cancer. And I went with her to the oncology appointment. It was the first appointment with the oncologist. And I was there and I listened, and I thought the oncologist explained it in such a great way. It was so clear, really at the level I thought my parents would understand. And we walked out of the room and I said, okay, Mom, what do you think? And she was so confused. She really had no understanding of what was discussed in that clinic. And that was a real eye-opener to me, because there I thought, and I think the physician also thought, they were explaining it very clearly. And the second we walked out, and my mom's an educated person, and she really didn't understand what was discussed in that visit. So that's where your role comes in, supporting patients beyond the clinic and being kind of co-educators for us. So again, I think clear communication is a form of care. I think every word we choose can help open a door, but we also don't want to close those doors. And I really think back, that patient I presented at the beginning, I see him now about 5 or 6 years later, and he's doing well and still on active surveillance. And he says, I think I overreacted, I think, at the beginning. And, now he's quite well, but actually now in a bit of a challenging situation, because he's still off work and hasn't gone back, and, things in his life had changed. So, I don't want to close the door, and I want to be able to provide the resources that patients need and communicate clearly. We have to make health information something that everybody can understand, not where you need a medical degree to decode it. And enhancing health literacy in the population can then also help to leading to greater equity in disease outcomes by holding organizations and government accountable. And I think a lot of the work that the CLL Advocates Network, and then there's kind of offshoot organizations, have done, especially when COVID-19 hit, for example, to show how CLL patients in particular are immunocompromised and may be or should be eligible for either earlier vaccines when they were sort of slowly being doled out, or mask mandates and things like that. So I think that's an example of where health literacy can lead to organizational and holding organizations and governments accountable. So I think the other panelists, I'm open to discussion now, but I also know we're moving on to the other panelists from advocacy groups from lower and middle income countries as well, and really looking forward to the discussion.
Thank you. We introduce Michael. Michael is co-founder of CLL Ireland and communication officer for CLL Advocates Network, inspired by his wife Jan's diagnosis. Michael has become passionate advocate, focusing on making scientific information less intimidating and more of patients.
That's
Please.
great. Thank you, Felice, and thank you. Great presentation. And actually, as I was sitting there watching the presentation, you covered maybe a lot of the points that I was going to make, but it's actually a help because it kind of lead me into it. Where I'm coming from, I come from a country, Ireland. It's a high-income country. When my wife Jan, I'm a care partner to my wife Jan, who was diagnosed in 2011. At that time, we only had chemoimmunotherapy, but the journey, or she doesn't like using the word journey, but the pathway of her diagnosis, it was nearly like a crash course in CLL. What I want to say right at the beginning, I'd never heard of CLL, never even realised that there could be a chronic leukemia, because when you hear leukemia, you hear blood cancer, the image in your head is the child that's going through treatment and the bald child and the fundraisers and things like that. I never realised there was a chronic. So it was nearly a crash course in learning all about CLL, because we realised back in Ireland was trying to get information, and the information was very, very outdated. Jan got sick actually very, very quickly, which is not the experience of most patients. Had a lot of autoimmune issues. And where I say that was a crash course in CLL, we first had to learn about CLL, but because there was no information in Ireland, we then had to reach outside of Ireland. And most of our information came from other patient advocate organisations. But what I first realised was that when you came across the international patient community in the high-income countries, it's not the same for the global south, but the patients not only knew that they had CLL, they also knew they had their chromosomal abnormalities. And that was another thing. It was like they'd put their name up and they'd say the diagnosis, the anniversary of the diagnosis, and then they would have all their, whether they had a 17p, p53. And so now we had to learn all about this. What did this mean? And we knew how important that was very, very quickly, or if you were mutated or unmutated. I kind of give you maybe a funny story. I remember Jan, not so funny that she was in hospital with pneumonia, an infection that she'd picked up. And I remember that I was walking out of the hospital and her doctor was walking towards, and he saw me and he was carrying all his files and his bag. And he put the bag down and he says, "Michael, I have some good news. Jan is mutated." So, and I was thinking, and I had just left Jan. I mean, she looked okay to me. So, you know, and I had to pretend I knew what he was talking about, but then I had to go back and find out. And I did come across Terry Hamblin. The late Terry Hamblin was a top CLL specialist in the UK, and he had a blog, and it was called Mutations of Mortality. And then I realised what that actually meant, and then I realised how important this was in making treatment decisions. So it's nearly like the learning about CLL was nearly like a college education. But the reason I'm telling you these stories is that I came from a point of view of no information. And what I maybe will try and say to us as advocates is that don't underestimate the patients that you're talking to or the care partners that you're talking to, because they may not get all the information right at the beginning, but as time goes on, and it took us a long time, you know, that I had to learn about CLL, I had to learn about autoimmune hemolytic anemia, I had to learn about ITP. In 2013, Jan was told that she had a Richter's transformation. I had to learn about Richter's. Had to learn about transplant. So that took us up to 2014. Had to learn about all the novel therapies. So it can be done, you know. So don't underestimate the patient community. And I suppose that's all I maybe have to add on that. And if you want to have a discussion of...
I invite to join us also Aleksandra Mladenovic from Serbia. She is from LIPA, Serbia National Patient Organization for Lymphoma and CLL. With nearly 2 decades of advocacy, Aleksandra has led project to strengthen patient knowledge and access, showing how health literacy approach can be updated across culture and resource. Please.
Thank you, but I have some slides, so please.
You have tried? Okay, no problem, no problem. Go to the speaker point.
Thank you.
And please, after we come back.
Sorry, you okay?
Okay.
So, hello everyone. Good morning. My name is Aleksandra Mladenovic, and I'm the project manager in LIPA. LIPA is Association of Patients with Lymphoma, CLL, and MPN in Serbia. And I'm also a patient myself. I'm in stable remission for more than 1 decade after the treatment of DLBCL, non-Hodgkin lymphoma. So this personal experience actually gives me a unique opportunity to understand some different perspectives, both as a patient and as someone working to improve care and care for others. Let me introduce something about my organization I present today. LIPA is a volunteer-based organization run primarily by patients for patients, and we support individuals and families through education, community, and support during treatment and the life after treatment. And most importantly, we advocate for access to innovative therapies because our country is non-European Union country, so we as patients directly feel the gap between our healthcare system and healthcare system in our in our neighborhood countries. And something about association, founded in 2006, almost 20 years. We has more than 1,000 members, 32 completed projects, and 4 ongoing projects right now. And why health literacy actually matters? Well, our campaign, One Name, Many Faces, has been active for years, but this is the first time that we have so many involved patients in this project. 7 years ago, we barely managed to collect enough stories for first book edition. And over the years, we have broken stigma, and now the campaign reflects a much broader spectrum of patient experiences, showing how health literacy and patient engagement have evolved over time, actually. And the idea is very simple. It is not enough that therapists and doctors exist. Of course, that's crucial. But the patient also need to understand their own care journey. And health literacy is essentially the bridge between what is done in medicine and what the patient truly understands and experiences. So this campaign, our campaign, One Name, Many Faces, shows how stories build a bridge from the disease name to personal meaning and to everyday life for every patient. And this is the faces of our patients with CLL involved in this campaign. And let me introduce you with campaign. This campaign is still running, and this time it focuses on 3 diseases: CLL, lymphoma, and MPN. As I said before, LIPA covering 3 diseases, hematological diseases. And the idea behind the initiative is simple, but it's very powerful: to raise awareness, to provide accurate information, and to advocate for better access to treatment and care. Notice, to treatment and care. Because, as I said before, we are non-European Union countries, so we have a limited access to innovative therapy. The core message is that diagnosis is not a punishment, but it's transformation, a moment that takes people rethink their lives and priorities in lives. So our goals were very clear: to create clear information so patients can better understand their diagnosis, to ensure access to treatment and care, and to help people feel supported not only by a healthcare system, but also society at all. And this is something about our campaign. This year, we had involved 39 patients in this campaign who shared their experiences through video interviews and testimonials. And their stories give us a unique chance to see the whole spectrum of health literacy, from people who know a lot and they want to be involved in every decision, to those who prefer not too much. To make these stories visible, we stepped out of the digital space and we organized photo exhibition with portraits of patients, where each portrait actually has highlight from their story and QR code linking to full video interview on YouTube. And this is not it. The exhibition were displayed in the busiest squares in 4 biggest cities in Serbia, including capital. And we organized education panels, spaces where patients, doctor, and other wider community, including media, could meet, talk, share experiences, etc. And the results. The campaign was covered nearly by all major print and digital media in Serbia. We had 70 journalists engaged in on-site reporting during exhibitions, appearances on 7 national TV broadcasts. This exhibition format allowed patients to be seen as individuals, as persons, not just the cases, and that breaks stigma and humanizing the diagnosis. Initiatives sparked dialogue about the needs of CLL patients and inspired solidarity within the community. And from these very clear results, also came up one small hidden story, little case study that gives us an extra insights into patients' experiences. So, we first noticed 2 extremes. At one extreme, just a second, this is correct slide. At the one extreme, we have a patient who researched everything about her disease and did not accept any compromise until she received innovative therapy through a special protocol, which is available in our country. As I said before, we have a limited availability for innovative therapy. At the other extreme, there is a patient who knew nothing, absolutely nothing about disease, not even what therapy he was receiving, and had complete trust in his medical team. I have to notice that both were successfully treated, but their paths and experiences were completely different. And this shows that health literacy can make many forms and does not always lead to the same behavior for patients. Most patients fall somewhere between these 2 extremes, and there is some examples. A retreated healthcare worker. She had medical background, of course, but she didn't know so much about her own disease. She had opportunity to receive an innovative therapy, and she's fine now, she's very well. Her story shows that professional knowledge doesn't automatically mean understanding one's own health, as you said before. We had patients on watch and wait, understanding that not treating can be a valid medical decision was crucial for him to not feel forgotten and to understand that he was still part of some health process, medical process. Patient with mutation, DLBCL to CLL, she's still on chemotherapy after first line of chemotherapy for DLBCL, when we're talking about available therapy in Serbia. So she didn't know so much about her disease or about treatment, about side effects, about mutation, anything about disease. So she takes part in our group psychotherapy sessions, and she now better understands and cope with her situation. And this example shows that health literacy is built not only through the information and knowledge, but also through community and emotional support. And we have one person, well-known sport figure. He tried some approaches outside the system, but finally he received innovative therapy within available protocol in Serbia. And this shows that even people with high authority and confidence must trust evidence-based medicine. It is very important. So what we learned? What do all these examples show us, actually? Health literacy is not the same as medical knowledge. Even healthcare professionals are not always prepared where they become a patient. It helps patients understand complex decisions, such example with watch and wait, and ensure they don't feel forgotten or supported or alone in this process. It is built through community and psychological support as much through the information. And finally, it improves patients to recognize the value of the evidence-based medicine, even when exploring alternative paths. Therefore, health literacy does not mean patient must know everything. It means knowing enough to actively participate in one's own care. This is the true bridge between medicine and the real life. And what we also learned is that health literacy cannot be built overnight. We need 7 years. It is a process. We created every conversation, every shared story, every moment of trust between patient and the doctor. Campaign like us shows that when we create space for dialogue, we build not just understanding, also dignity and solidarity for patients. So if you'd like to know more, share your experiences, or connect with us around common ideas, please contact us. Thank you. Thank you for attention.
Aleksandra, because what you say, your presentation was a very summarize of this session, no? What we need, what we are doing for patient support. You have question? Some question from the audience? No. Yeah, one.
I guess the word, hearing the presentations, if the word that brings to mind, I guess, reminds me of the presentation yesterday on resilience. And we had an interesting case where in Serbia, and Michael, as you as well, having more knowledge built resilience and ability to go through the system. And Alina, Dr. Gerrie, your situation is you gave the person the information, and yet they didn't read it or they didn't follow it. So I guess my first question is, do you have any insight as to why that person did not follow up and read the information that could have potentially stopped them from making those life-changing decisions? And I guess if the other panelists want to comment how the link between resilience and what you've experienced, but I'm really interested in what insights you can give us. Maybe you don't have any, I don't know.
Yeah, it's a great question because I've reflected on it in that case. And obviously there's many things with a person and what they're going through that might have been outside of just the CLL diagnosis as well, that I'm not, don't have the full picture. I think that one of the things that I took away from it is, when we usually do talk about how CLL is not curable, but maybe changing how I communicate that information, and maybe not right away. It is something that people will read, though, if they read about CLL. So you do know they're going to go home and read that. So we do try to say it, but I've kind of softened how I explain that and really emphasize that the treatments are excellent. They will you can have the disease completely gone for a period of time. It just will eventually creep back. So I think that's something that I've learned personally to adjust how I communicate that. Now we have stronger nursing support in our clinic with nurses who are more specialized in CLL. So now we often I could arrange a follow-up phone call if I felt someone was particularly anxious or was worried about them during clinic, thinking maybe they didn't quite grasp everything. So I think that's something I could do now. At that time, we didn't have the resources with a nurse specialist. So I think that's where the systems issues really come in. Having nurse specialists, as was also mentioned in the earlier presentation, is so helpful when we're limited in time when we can talk with patients. Yeah.
I've always assumed that having information builds resilience, but in your case, a patient had information and it didn't.
Well, you don't know that they're necessarily going to read it. And actually, speaking to what you said, not everybody wants to read everything and reach out to all these organizations. So it does come down to what you say in clinic and what they hear. But even if you say all the things that you think are the right things, you don't know how it's perceived and taken. Yeah.
I think if I can just add to that, the early days of the diagnosis, and maybe it was kind of an unusual situation that I was the one that was actually picking up all the information, and for probably about 12 months, Jan didn't want to know.
Yeah.
And any of the information I was getting, and back at that time, because we didn't have the options of the targeted therapy, I was just picking all the positives, you know, that glass is half full. So I didn't tell her kind of the bad stuff, you know, that's you know. And but I actually think that, and it's why I'm so passionate about the network and the work, and Alina had actually mentioned this, that the patient advocate organisations, and I mentioned it this morning at the session as well, is that when a patient actually comes to one of the information days, and us as patient advocates, we're not giving medical advice, and that's what we need to be really careful of in the health literacy. The medical advice has to come from the clinicians, but we bring the clinicians in and they tell the story. And where I'll give an example is that when we were looking at treatment options back in 2013 in Ireland, there was one clinical trial for CLL patients, but it was for relapsed refractory over 65 patients, and Jan was 39, a mother of 4 at home. So there was no options except for chemoimmunotherapy. So we had to travel, but it's because we had gathered all the information and the trial results at all the different conferences and all. So we had to learn how to read these and understand them. As time has gone on, because the language is actually very similar from all the doctors, I now understand and know how to, that Kaplan-Meier curve, how to read it. But again, not all patients. And you mentioned that patient that came in, heard that information. You did do a good job. There's no, but I know you might feel that you didn't do it. Like Ben Kennedy does a good job at explaining to the patient, but the patient just may not pick up that information. But what I will say is where the information is really, really important is that back in Ireland, because we've had these information days and that clinical trial that we had back for 9 patients, we then had a clinical trial, which was the German study CLL17. And when it opened in Ireland, very, very quickly, 40 patients, with 40 placed on that trial, it filled really, really quickly. And Cancer Trials Ireland actually put up a tweet one time, and they said, we want to thank CLL Ireland for their empowerment of the patient community. I didn't particularly like it because it was like we don't give advice to say patient you'd go on the trial. They kept that trial opened, and 87 patients ended up on that trial. And of all the Nordic countries in Ireland, we had the highest participation because the patients had the information. They knew what they were looking at and they knew what they wanted. And that's where us as organisations, you mentioned the nurses as well, are really, really important because the doctors only have so much time.
I think the patients actually feel some kind of fear and don't listening actually.
Yeah.
And I think this is the main role of organization as LIPA, as to provide information and to show patients then you can survive, you can live with that. And that's the main story.
One of the rights of the patient is to know how there are some clinical trial. Many times the doctor don't explain about clinical trial and don't put on the table this option, but talk about just the option they have in their hospital. But don't talk about if you want, you are eligible for another kind of system, you have a possibility to join this clinical trial. This is another right for us.
Yeah, that's actually a really good point. I was going to say that. I think it would be very reasonable as advocates to explain to your patient groups that it's okay to ask, what else is out there, maybe not at our center or in even our country, if a person might be willing to travel, but even to open that door to that conversation so that at least maybe if chemoimmunotherapy is all you have, but at least they're aware of what else is out there. And then the doctor will think about, how can I access this? Or maybe I should look up I know somebody in this country, maybe they do have that trial open, maybe I could contact them. So really empowering patients to ask their doctors, hey, anything else out there? What if I could travel, where could I go? Or if you did have all drugs available to you, what would you want to give? Recognizing that there's limits, but I think sometimes we do that. We forget that people, we're focused on what we have available, but I think the more we talk about what else there is, then it allows patients to advocate for that and seek out their own resources if they have that.
And I have to say there is a limited access to clinical trials too, so
Yeah,
we
exactly.
have a big problem actually.
Yeah.
Okay, from the audience, please.
Actually, I have a comment on behalf of the medical professionals. There is a slim line between knowledge and communicating the knowledge. I mean, there is the advanced and contemporary Western approach to communicating the diagnosis. And I have seen papers coming from Western countries saying, your cancer is called this and that, it is incurable, and the prognosis is 5 years. And then there is the approach which my school has. It's not unique. It's the other so-called conservative approach, where you avoiding telling the patient directly that your cancer's name is this. You say your disorder's name is this, or your disease name is this. And you don't say it's incurable, you say it's a serious disease, but there are means to cure it. Knowing what kind of psychological effects some words and some ways of communication can cause, you learn how to adapt your level of talking to patients according to their educational, understanding, intellectual, cultural, every level. And that is why in my country some people say for this disease you should seek a doctor with white hair. Experience is something that, I mean, people often say wisdom is acquired by age. It's not true. Wisdom is acquired by experience. So there are modifications a doctor must know how and when to implement in order not to produce the ultimate stress for the patient. There is 2 talks we do. One is with the patient, one is with the family. The family must know the naked truth, but the patient is always to be put in a position to remain hopeful.
Can I just add to or say something in response to that?
Did you want to add while we? Yeah, go on.
Sure. Well, I may not have white hair, but I do have experience. And I agree. I respect that there's different ways to communicate. I completely agree in maybe it's Western or in Canada, but we do feel that the patient needs to know and needs to be empowered that way. And I can't not say cancer. They come to the BC Cancer Agency. It's very clear that they're at an oncology center. So it is a word that we have to use. And I think that now in the the world that we're in with the internet and the information that's out there, and I agree that there's different levels, and certainly I have many patients who will not access the internet, and I might tailor my communication to them differently. But most people nowadays are going to be able to access the internet and find that information out there. So I think it is important that we, as the healthcare providers, try to communicate parts of that information over time where appropriate for a particular situation.
Thank you. And I'm just going to follow on for that because I was diagnosed at 38 and I didn't want a white-haired doctor because I wanted to be growing old with my clinician. So my clinician was probably in her early 40s with 4 children. So sorry, my question is about the power of AI to help as for standard of care for note-taking in sessions. I've lived with this disease for 14 years, and for the first time last week, when I actually had a really seriously bad news, I've relapsed post-CAR-T, my whole body shut down, even though I'm a very highly engaged, educated patient, and my clinician had asked permission to take notes using AI. And they were uploaded to my portal at the Peter MacCallum Centre in Melbourne. And a day later, I was able to read this full hour-long consult that I had with very serious decisions to make that I've now been able to share with my support network and other doctors. And I think such a simple tool that has actually really, really changed things for me over the past week and could be used anywhere in the world Are you using this? Are you seeing this as a potential to really help patients bridge that gap in health literacy?
Yeah, thanks for sharing your experience. So we're in the infancy, certainly at an organizational level. It's a big thing to implement a new system, as anyone who works in a large organization, I'm sure, can experience. So we're just starting in our organization, but certainly clinicians in Canada are using it in private practice or in kind of their own smaller clinics. And I definitely see the appeal. It's really interesting, both you and Dr. Kennedy discussed patients seeing their notes. That's a new thing for us. We're just starting that. I'm not sure, Raymond, in Ontario, if that's happening yet, but that is a shift in how we dictate our notes, how we use that communication, because we usually are doing it more as a note to ourselves and also to communicate to the primary healthcare provider. And I think just that concept in general will definitely help empower patients. I'm always happy to give people their notes if they want them, but it hasn't been our standard to send them to the patients. And now patients will be able to see them on our new portals that are coming. So I do think that's a big shift that's probably happening across in many countries, and that will hopefully help empower patients as well and help with health literacy.
I might just jump in because in my current role at the Children's Hospital in Queensland, and we're actually broadening out a trial with medical AI scribes. So it's not a chat GP, it's software that meets very regulated privacy requirements. It's basically set ground rules. So it's not there to diagnose, it's not there to do any of that elements. And Deb kindly shared her notes with me to actually look at the content that's there. And what we're seeing is, in a busy clinic, it means the doctors are actually looking at their patient, engaging. So there's that warmth, there's that interaction, and the AI is taking the content. And so, you know, therefore the documentation for the clinician and remembering at the end of the back-to-back kind of day, really getting that rich information of what was shared. And then importantly as well, and I haven't said this to Deb yet, so, you know, may or may not be a spoiler alert for her, but, you know, it can be set up in such a way that when Deb leaves the room, the doctor can then say, please use my patient format to pull the information in to this space. Please then take this information as a referral to my colleague to talk further as a haematologist. Please also then transfer this into a letter back to her GP. So it actually then changes the language depending on who the recipient of the letter is by just words and within a very short period of time. And it's really enhancing, you know, the clinicians are feeling like they're having those better conversations. People are walking away a lot quicker. And to Deb's point, you know, even while she is an experienced and an educated person and would have imagined that she would have walked out of that appointment remembering everything, that wasn't her experience, but she now has that to help with her processing and decision making with her support units. So it is a very interesting space, and I may be biased because we're seeing such great results. And I've also been on the receiving end as a parent with a child, and how that sort of meant that the doctor could just speak with us and answer my daughter's questions. But I'm going to hand over to another question in the middle of the room.
I think this is a fabulous discussion that we're having and has real value. John Greensmith, by the way, CLL Support UK. We're all here because we're motivated as advocates to help patients. And one of the frustrations that we feel, and we know from survey results, is the term, from a patient, if I knew then what I now know. And that's why it's a frustration, because you just got to look at the poster displays for the wealth of information from all of the countries that are here that's available. And what's key to us is getting to the patient early. And the early opportunity to get to the patient is from the clinician at the initial appointment. And if the clinician signposts to the support network, to the advocacy organization within the country, that is key. The patient is in fight or flight mode usually, and the amount of information they can absorb is tiny by comparison. And your example was fabulous in that sense. So getting that information to the patient, whether it's a pamphlet or it's a website address, and saying, these people are reliable and they have information that's understandable, I think is key. So that the hookup between the advocacy network and the clinical community cannot be underemphasized. So it's a comment rather than a question.
That's a really excellent point. So in our clinics, we now have, we've had it now for a few years, but basically a pamphlet with the different organizations, particularly CLL Canada, and then we have some larger leukemia, lymphoma organizations, and we give them that in their clinic. But that sounds like a very simple thing, but until you actually have that, really came about when we had our clinical nurses in clinic who could help us. It's one thing to make it and I could print some and put them there, but to keep it updated, to make sure that every patient gets it, to make sure, you know, the website maybe has changed or the, you know, information might have changed. You do need that support behind you. And I think as clinicians, we can do better. So I'm kind of the main CLL lead in my province. I can certainly, maybe that makes me think, what I should do is circulate that to my colleagues to make sure that everybody is doing this. We're doing it in my center, which is the larger center, but, you know, make sure that everybody's doing something similar if it fits. But yeah, I think that's a great point. And good to know that that's where one of the barriers are from an advocacy group point of view, is really getting it to the patients on the ground. So as clinicians, we need to spread that word.
We're almost right at break time. I know we've got one more question. We'll have to leave it there. Like, I'll let you ask, but just mindful of the time, because there is some instructions I need to give you before we break. But we'll run to this question.
Okay. Sometimes we get more information. From my experience, I need to start for the treatment because the lymph nodes on my neck go up over 15 centimeters. And my doctor told me about the CLL, and I was thinking to learn what she said, and after that, she gave me a bump. You are not simply CLL, you are UCLL. What is UCLL? Unmutated. And unmutated, she showed me some graphics. And to be honest, after 5 years, I'm not understand exactly what is UCLL. Maybe it is some college of United States UCLL. That's it.
Yeah. One of the hardest things to explain in clinic, especially in a short time. Absolutely.
Yeah.
Yeah.
I really want to thank everybody for such great engaging questions, and personally thanking our speakers as well. We are breaking to break, and so hopefully you can tackle a few of these guys while you grab your coffee if you do have some extra questions. I guess what I really pull from with Aleksandra, that health literacy, it's a spectrum. And similarly to what we spoke about earlier, it's not a one-size-fits-all. And we know in our research and the work that AJ and Pika had done with our lived experience survey, that half amount of information or half amount of understanding, it has an equal kind of impact negatively on a person's quality of life as being given no information at all. So it really calls to task how important it is to be working with that person in front of us, and for us patient organisations to be, as you mentioned, that connection point, and Michael sort of alluded to it, you know, the face of the carer who's like, yes, I understand exactly what you're talking about. I have no idea what you're talking about. And now I'm going to go research and connect with community, which is sort of, you know, that call to action for all of us here, making sure we're addressing that health literacy spectrum of those people that are diagnosed. And as a nurse, I can completely understand. My husband saw a cardiologist, and the last thing I said to him as we walked in is, do not tell them I'm a nurse. Because yes. Oncology, hematology, very good. Cardiology, not so much. I will again thank all of you for your time and your expertise, and for those in the room for asking the questions.